much for attending our Retina symposium here at the SOE. We thought that one of the hottest topics would be artificial intelligence in retina imaging and retina imaging as a whole and artificial intelligence as a whole. So that was the topic of our symposium. And it's my pleasure to invite Dr. Martin Zinkernagel, who will give the first talk on FLIO in retinal disease. Martin?
Dear Anat, dear Sebastian, thank you very much for allowing me to talk at this session. I'm going to talk about fluorescence lifetime imaging ophthalmoscopy. We used artificial intelligence on it once, I believe, but it's still done with proper intelligence. So. But maybe later on we'll have some more artificial intelligence. So these are my financial interests. I'm sure some of you have seen the principles of fluorescence lifetime imaging. Just to go through it quickly. So we can assess autofluorescence in two ways. We can either look at intensity, so the amount of photons coming back to the detector. And you see a typical image, image over here of a patient with Stargardt disease. But we can also have a look how long it takes for the excited fluorophore to get back to the ground state. And you can see here a schematic that we use a laser to excite a fluorophore, and this is then excited and releases photons to get back to the ground state, and this time can be calculated and assessed, and basically is the fluorescence lifetime, so the amount of time this fluorophore glows. The FLIO device scans the retina, and for each pixel, you see that here, the scan for each pixel, lifetimes are measured. You see that here, and these lifetimes are in the range of nanoseconds, so very, very short lifetimes. Now, the calculation, I'm not going to go into details. It probably would require some higher intelligence, which I'm not capable of. This is the equation here. And what we get is, for each pixel, we get this decay curve here. In the end, we have a color-coded map, and you see that over here, where short lifetimes are color-coded in red, and long lifetimes are color-coded in blue, and you see the histogram here. So this is between about approximately 200 and 600 picoseconds. Now, just to sum it up, this fluorescence lifetime imaging ophthalmoscope is based on a Heidelberg engineering spectralis system. It uses a picosecond pulse diode laser. It needs to be it needs to have a certain interval between the pulses, otherwise you get bleaching into the next pixel. And it uses a 473 nanometer laser with 80 megahertz repetition rate. And the lifetimes are measured in two spectral channels. So there's a short spectral channel and a long spectral channel. Now, let's have a look at the normal FLIO image. Once again, you see the autofluorescence intensity image over here on the left and the FLIO image on the right. You can see that the macula has quite short lifetime, so it has a red color, and the vessels are longer, so they're in blue, and you can see here that this is well defined by these decay curves. So this decay curve is quite fast, so there's a fast decay of fluorescence, whereas above the vessels and the optic nerve, you have a longer decay curve. Now, we looked at a bunch of healthy subjects, and what you can see here is that there's some dependency on age. So the older you get, the longer these lifetimes tend to be. So the older you grow, the longer you glow. You can see that here. So this is a young patient, and it's quite short, these lifetimes, especially in the center. And when you look at this 60-year-old male patient, the lifetimes are generally longer, and this is statistically significant. We looked at the influence of the lens, and you can quite nicely see here that in the short spectral channel, there's some scattering up here of phakic patients, scattering the lifetimes, whereas as you look at these blue dots, which are pseudophakic patients, these are much more equal. So there's less, obviously there's less influence in pseudophakic patients. But if you look at the long spectral channel over here, this influence of the lens seems to be much less. So it seems to be reasonable to look at the long spectral channel, especially in patients with cataracts. Now, you may wonder where these lifetimes come from, which fluorophores, and nowadays we have quite a good idea about where these lifetimes come from. We can just sum up this table here, and what you basically can see that zeaxanthin and lutein have a very short lifetimes down here, very short lifetimes. The same for retinal, also very short lifetimes. And lipofuscin, collagen, and elastin have very long lifetimes. And we're going to have a look at examples now of retinal diseases mirroring these components. Now, as I just mentioned, macular pigment, so zeaxanthin and lutein, you can really nicely see that in the center, these lifetimes are very short, so in this red color. And when you look at studies correlating these short colors in FLIO with macular pigment optical density measurements, you can find quite a nice correlation. So this really correlates to the conventional method of looking at macular pigment. As you all know, sometimes it's difficult to look at macular pigment optical density, especially in the presence of a macular atrophy. And when you look at FLIO image, this seems to be much more easily demarcatable. So you can see here patients with geographic atrophy here. And in the FLIO, you can nicely see this macular pigment. So this is a patient with macular sparing, and this is a patient where the fovea is already involved. And we looked at this systematically, and we could find that even in the presence of foveal atrophy, we could identify macular pigment quite nicely. So this could be an additional biomarker in patients with geographic atrophy. We also looked at border zones, and you can see here this classification of geographic atrophy with fundus autofluorescence. We did the same with FLIO. Additionally, what you really can nicely see is that in the border zones, there is additional signal which allows you to quantify these border zones of geographic atrophy, and this may be a nice parameter to look at progression of this disease. Now, we just recently looked at fluorescence lifetime imaging in patients with macular off-retinal detachment, looking at macular pigment, how this could influence visual outcomes after macular retinal detachment repair for macular off detachment. And what we found is that it is quite a good marker to predict visual outcomes. So the shorter the lifetime after retinal detachment repair, about a month after surgery, the shorter you have these lifetimes in the center, the better will be the visual outcome after 6 months. So it's a predictive marker we can use to inform the patient about prognosis. Now let's look at central serous chorioretinopathy. You all know these images, so these are autofluorescence and infrared images. You can see in the OCT there's quite a lot of subretinal fluid. If you now look at the FLIO image at the bottom, you can see the macular pigment down here. And you may wonder whether there has been an increase in macular pigment because the red color seems to spread into the area of this subretinal fluid. If you compare it over here, there's no subretinal fluid, and this reddish short lifetime area is quite well contained to the fovea, whereas here you have this blob of short lifetimes. Now, when you look at this a little bit closer, you can see that these very short lifetimes, they derive from areas with elongated outer photoreceptor segments. So when you remember the table we had a look at before, this retinal derivative with very short lifetimes, we believe that these short lifetimes you see in this area of detached retina here with the subretinal fluid really derives of retinal because this is accumulated in these outer photoreceptors and cannot be digested by the retinal pigment epithelium. And it ultimately may give an indication whether these photoreceptors are still viable, although we don't have microperimetry yet to verify these hypotheses. Now let's look at Stargardt disease. Up here you have the autofluorescence with the characteristic flecks. If you look at the lifetime images, you see that these flecks have different colors, and this is something that struck us when we looked at these patients for the first time. We have flecks with very short fluorescence lifetime colors, and we have flecks with quite long fluorescence lifetime colors. You see that here, these blue and red dots. And if you look at the OCT and correlate these flecks with OCT findings, you can basically see that these blue flecks are more demarcated. They're more in the area of the retinal pigment epithelium, whereas the red flecks, for example, here, are more of a type of elongated photoreceptors in this area. You can well appreciate that here. And this may again be an indication that we have two kinds of stages in these flecks, namely very early flecks with short lifetimes, which would represent accumulation of byproducts of the visual cycle, possibly retinal derivates, and long lifetime flecks, which represent accumulation of lipofuscin, which are at the more advanced stages. So you can really differentiate these flecks, and this would also be important, especially if you look at gene therapy or other therapeutic approaches to differentiate these flecks, because then you could really target early flecks and see whether you could bring them back to normal lifetimes, or whether you could prevent these short-lived flecks to turn into longer lifetime flecks, which would represent accumulation of lipofuscin. What we can also do with these images, we can construct two-dimensional plots, much like you do in flow cytometry, and you can look at different components of these lifetimes, and you can really identify specific areas of the retina, and you can nicely demarcate these flecks in these two-dimensional plots, and you can quantify the amount of lifetimes within these 2D plots. And this is just to show and to confirm or an additional confirmation of what I just showed you before. This is ex vivo studies where we looked at retinal with very, very short lifetimes. You see here around 50 picoseconds, and A2E, a product of a byproduct of the visual cycle, which has much longer fluorescence lifetimes and is associated with lipofuscin. Now, to sum it up, fluorescence lifetime imaging is very reproducible. We did, and other groups did, validation studies to look at the reproducibility of this device. And nowadays, there are about 4 or 5 devices in use, and I think there are probably more to come, hopefully. FLIO provides information about outcome measures for macular pigment. We saw that in normal patients, but also in patients with age-related macular degeneration. We can identify specific and disease-specific patterns with fluorescence lifetime imaging, and it may provide additional parameters for outcomes, especially in diseases such as Stargardt disease, or I haven't showed the images, or choroideremia. So at the end, I would like to thank my group in Bern, but also the colleagues from Heidelberg Engineering, which helped us, especially initially with the device, and our other industrial partners. Thanks for your attention. I'm happy to take questions.
Thank you very much for this excellent talk. Are there questions from the audience?
If not, I have a question.
Okay.
Martin, I think it's really fascinating, this technology, and I want you, if you can elaborate about the importance in geographic atrophy. Actually, you showed 2 things. One, that in the center, you can still see where there still is pigment, and the second had to do with the periphery of the lesion. So maybe you can elaborate for us, because it's such an important disease, to tell us in what way do you think it can change the management of the patients in the future or today, or?
So at the moment, because we're lacking any therapy, it's maybe irrelevant. But I think especially this foveal sparing, where you can identify macular pigment, and what we could show is that it quite nicely correlates with visual acuity. So if we would have something to treat these patients, this may be a parameter to monitor disease progression, because
like an outcome for a study, for example?
Exactly, an outcome parameter to measure success of a treatment. And the other is that if you can look at these border zones in a quantitative way, it may also make monitoring easier for possible therapeutic agents.
Okay, so thank you very much.
Thank you.
Next speaker will be my co-moderator, Anat Loewenstein, OCT-Biomarkers for macular disease. Anat.
How do I get to it? Okay, good morning. So I'm going to talk a little bit about biomarkers as a whole, not only about OCT biomarkers in retinal disease, and I will focus on diabetic macular edema. The reason I'm not talking only about OCT biomarkers is that actually there is very little biomarkers that are validated and reproduced in multiple trials in OCT. These are my financial disclosures. And I'll start by presenting you this 80-year-old patient of mine who has significant macular edema due to diabetes. She was treated by 9 injections of bevacizumab. She did not respond. She was treated by 3 additional ones and still had edema. At this point, she was switched to ranibizumab, still didn't respond after 6 injections, switched to aflibercept, and responded nicely. So it's a patient that didn't respond to 2 anti-VEGFs and responded to the 3rd one. This is a 63-year-old patient of mine who come with this significant edema, is treated by 6 injections of bevacizumab, doesn't respond, switched to Ozurdex this time, and responds nicely. So the question is, if when we see a specific patient, if we can predict if he will respond to a specific anti-VEGF while he will not respond to the other, or that he will never respond to an anti-VEGF and will respond to a steroid. Basically, we want to know, when we want to use a biomarker, if we could predict the outcome of treatments. Are there any biomarkers whatsoever to help us predict if the patient will respond, what will be the level of response, and if there will be differential response between various agents? So we are looking for biologic biomarkers. What is a biomarker? The definition of the NIH claims that a biomarker is a characteristic that, first of all, needs to be objectively measured. So this is a very important point, that the biomarker needs to be measurable in an objective manner, and then it can be evaluated as an indicator of either a normal biological occurrence or a pathological process, and maybe, and this is actually what we are looking for, a pharmacological response to a specific therapeutic intervention. There are multiple things that can be looked at as biomarkers. It could be a functional test. For example, visual acuity, ETDRS vision, Snellen vision could be a biomarker. Reading speed in various modalities can be a biomarker. Microperimetry, contrast sensitivity, and color vision. So one thing that can be a biomarker is a result of a functional test, and I will show you a few examples. The other assessment that can be viewed as a biomarker is a biological sample. If we take a sample from the vitreous or aqueous and we look for VEGF or other cytokines or for messenger RNA, maybe one of these will be a biological marker that will tell us if a patient will respond, what will be the level of response, and to which agent he will respond. And of course, it can be an imaging test. It can be OCT, fundus photography, OCT-A, or fundus autofluorescence. The NIH differentiates between 2 types of biomarkers, a prognostic biomarker and a predictive biomarker. The prognostic biomarker identifies how much improvement is expected from a specific therapeutic modality. And a predictive biomarker is actually really, really important because it can identify potentially patients who are likely to have a therapeutic benefit, and thus will help us select between various treatments. So in diabetic macular edema, there have been multiple of biomarkers that have been suspected as being indeed predictive: systemic, biochemical, molecular, and ocular. From the systemic parts, the 3 that are listed here, type of diabetes, blood pressure, and hyperlipidemia, have been implicated as biomarkers, but the only one that I found that was really significant was the level of lipids, and also only for the development of diabetic macular edema and not for the development of the level of retinopathy. From the biochemical ones, we know that, of course, hemoglobin A1C is significant, and it's interesting to know that a nice correlation with macular volume has been found to a cytokine. I've seen many, but this one was the most convincing one, ICAM1, that was shown to be nicely correlated, levels in the anterior chamber, with DME severity with macular volume specifically. So this is a biochemical biomarker. The molecular ones, I didn't find anything that was convincing enough, and now we'll go to the ocular ones, which are really important. So basically, it's very simple. One important biomarker is the level of visual acuity at baseline, and it has been shown repeatedly in many studies of DME. So these are the 2 ranibizumab arms from protocol I of the DRCR-NET. It had 4 arms, but I'm emphasizing only these 2 that were treated by ranibizumab. When you look at the visual acuity over 5 years of the whole cohort, you can see that basically, whether you gave laser up front or in a deferred manner, it didn't matter. It was the same. But if you stratify by visual acuity, you can see that if the patients had a bad visual acuity to start with, then the laser actually did harm. So baseline visual acuity is a prognostic, predictive biomarker not to treat with laser up front. And it has been repeatedly shown as an important biomarker, the baseline visual acuity. This is data from the UK electronic medical record data, which shows that if the visual acuity was good, then there isn't any improvement in visual acuity in the next stages. It's because of the ceiling effect, but still it is a biomarker. And of course, it was repeated in protocol T, when you had a good visual acuity, you responded nicely to all drugs. When you had the worst visual acuity, aflibercept was better than both drugs after year 1 and better than bevacizumab at year 2. Another important biomarker is the lens status. This is again protocol I, and now I'm showing you the 4 arms of the study, and you can see here these curves are the ones that I showed you before, and this one is of the group that was treated with triamcinolone. So you can see that it started in a nice manner. This is the whole cohort, improving nicely and then decreasing. But this was because patients were mostly pseudophakic. Because when you look at the pseudophakic eyes only, then triamcinolone did almost as good as the anti-VEGF agents. So a lens is really important, and it was shown in the MID trial. When you look at the pseudophakic patients, then Ozurdex was beneficial at every time point as compared to phakic patients where the visual acuity decreased. It was shown in the Bevodex trial, which compared bevacizumab and Ozurdex and showed that in the pseudophakic eyes, both drugs did the same. And it was shown in protocol U of the DRCR-NET that investigated the issue of combination of a steroid with anti-VEGF and showed that in the pseudophakic eyes, the combination was beneficial. In the phakic eyes, it was even harmful, probably because of the development of cataract. Another biomarker that is an ocular one is the existence of intraretinal lipids. And it has been shown in the Bevodex trial that even though both drugs were the same, when you look at the area of intraretinal lipids and at their distance of the fovea, the patients that were treated by Ozurdex, plotted in the white columns here, did actually better than the patients that were treated with bevacizumab. And there are multiple parameters that have been investigated as OCT biomarkers in the management of diabetic macular edema. And I will start by showing you this study that was done by a group of young retina specialists that I was mentoring, the International Retina Group, and they looked at multiple OCT biomarkers in diabetic macular edema. They asked themselves the question, why of these 2 patients, both of whom have macular edema and both are treated with Ozurdex, one responded nicely and one did not respond? And they looked at 6 OCT biomarkers, potential biomarkers, the level of hyperreflective foci, the level of cyst size, cyst location, existence of subretinal fluid, vitreoretinal interface, and inner segment, outer segment integrity. And I will just show you the ones that had a correlation. So the first one is the existence of subretinal fluid, and I want to argue here that the existence of subretinal fluid is consistently an important biomarker, OCT biomarker, in the treatment of DME, because the existence of subretinal fluid was predictive for visual improvement. So if a patient has subretinal fluid, he has higher chances to improve with treatment. The level of hyperreflective foci was also important, and it was predictive in a negative way. So eyes with less or no hyperreflective foci gained more vision. It doesn't claim that Ozurdex is not good for these eyes. It's just that this is a marker for severity of disease. So these eyes respond not as good to Ozurdex, and I think also not to other drugs, because it's just a level of severity, both when you look at the quantity and when you look at the location. And the very obvious biomarker in OCT is the integrity of the photoreceptor layer. So we know it from clinical practice, but it has been shown here and in other studies repeatedly that the integrity is very important. Eyes with intact inner segment, outer segment layer, ellipsoid zone, gain more vision than eyes that do not have an intact laser. So these 2 patients that we showed you, that I showed you, that one responded and one did not, are not the same, because the one that didn't respond doesn't have subretinal fluid, has many hyperreflective foci, and the inner segment, outer segment layer is damaged. as opposed to the other patient who does have subretinal fluid, does not have hyperreflective foci, and the inner segment, outer segment layer is intact. So you have here 3 important OCT biomarkers for the management of diabetic macular edema. Other studies look at a little bit different OCT biomarkers, and I want to mention the study of Jennifer's son that was already published a few years ago, but it's also been repeatedly shown, and she looked at various OCT parameters, but I think her biggest contribution was the coining of the definition of DRIL. DRIL is disorganization of the retinal inner layers, as opposed to the outer layers that was looked at in many previous studies. And she stratified the patients to chronic disease, where the retinal layer boundaries can only be partially identified, such as these patients, or non-chronic, where you can nicely identify the retinal boundaries. And she was able to show that if DRIL decreases over the first treatments, then probably the visual acuity will be better than if DRIL does not increase. So it is another OCT biomarker that is looked at as important. It has been repeatedly shown as important also in a study that was done in Mexico by Arturo Santos, showing again that the existence of DRIL is an important OCT biomarker to predict the response to treatment. Some other OCT parameters were suspected as being biomarkers and were studied by Ursula Schmidt Air Force in a study that was recently published in BJO. And she looked at various parameters, but I'm only going to show you the positive one. And she identified that the height of intraretinal cysts spaces at the baseline was a very good predictor, better than central subfield thickness. And that was true when you look at the visual acuity. This is a post-hoc analysis of one of the trials, and it was true when you looked at patients treated with ranibizumab only, ranibizumab with laser, or laser only. Also, subretinal fluid had a trend to show a positive impact. However, the height of the intraretinal cysts is also most probably an important OCT biomarkers. So I showed you the biomarkers that I think that are important. And from the OCT ones, I think that we have important OCT parameters that can give a hint as biomarkers: the level of subretinal fluid, DRIL, hyperreflective foci, integrity of the inner segment, outer segment layers, height of intraretinal cysts has been repeatedly shown in a few studies and not only in one of them. Thank you very much for your attention, and I'm very happy to take questions.
Thank you. Thank you, Anat, for this excellent talk. Other questions? So, Anat, visual acuity is still the best biomarker.
Absolutely.
And so why we should do all this meticulous grading on the OCT?
Sebastian, I think it's an excellent question, and that's why, because the topic that I was given by you was OCT biomarkers, but when I looked into the literature for this, I found it not as good as visual acuity. So I allowed myself to deviate from the topic because I got convinced that, you know, it's like saying that being healthy and rich is better than being sick and poor. If you have a good visual acuity, it almost doesn't matter what treatment you are getting. Doesn't matter, you're doing well, and doesn't matter what your OCT parameters are. Still, baseline visual acuity is the most important parameter.
Thank you. So then we go on. Next imaging modality, OCT-A in diabetes by Giuseppe Querques from Milano. Giuseppe.
Good morning, and thank you very much for the invitation. So, may I have my slides, please?
You have to find them yourself.
Ah, okay. Here it is, okay.
Let me feel that I help.
These are my disclosures. So, OCT-A in diabetes, not in diabetic retinopathy. This is my topic. So we will try to see together the different features that we can detect with OCT-A in different aspects of diabetic eyes and diabetic patients at the level of the retina. This is my starting slide. As you can see, there have been several publications these past years about the role of vascular changes or structural changes in the retina as the first moment in the development of diabetic retinopathy. And so far, I must say that there is still no consensus. So we don't know still if it's coming first vascular changes in diabetes or first loss of retinal cells. Starting from this, we did this, that was the first study in its kind about diabetic patients, particularly patients with the type 1 diabetes without any sign of diabetes, looking at fundus examination. And we looked at different aspects, and particularly at FIZ and at vascular complexities of vessels density. This is the way we did the analysis, and we skeletonized the vessels in order to get the same influence from all different vessels, so large or small vessels, and we excluded the fovea. These are the results. So we compared diabetic eyes, diabetic patients without signs of diabetes with age and sex-matched normal subjects. These are the results. As you can see, all the anatomical structure, at least for what we can detect with a structural OCT, appeared normal. And this is relative to RNFL and to ganglion cell thickness. So no changes in eyes without signs of diabetes, but still diabetic. And these were post-pediatric patients with at least 5 years of diabetes. When we looked at the OCT-A, indeed, we realized that there were already some changes, and these changes were particularly evident at the level of the deep capillary plexus with some kind of loss of vessels in the deep capillary plexus. So it seems, based on these results, that as far as we can detect with current technology, and I mean structural OCT and OCT-A, we cannot detect in the very early phases of diabetes, so without detectable changes on fundus examination. We cannot detect structural changes, but we can still find some changes at the level of the deep capillary plexus in terms of loss of deep capillary plexus. And this is probably suggesting that what is coming first is are vascular changes, and what we see on a structural point of view may probably comes later. But still, we have to questioning about what we can currently see with the current devices. I mean, the absence of changes detected on a structural OCT doesn't mean that we don't have changes, but at least it means that we don't have changes that we can detect with current technology. This study was then replicated by other groups demonstrating more or less the same results. So it seems that both in type 1 and type 2 diabetes, what we can nowadays detect as a very early phase of disease is only by means of OCT-A. Then we move to diabetic macular edema. And nowadays, we know how important is the application of OCT-A. And this mainly because this is the first time that we can detect 3D or pseudo-3D visualization of different plexuses. And so we know that we can isolate, distinguish the superficial, the deep, probably also an intermediate one plexus. And this is really the first time that we were able to do such kind of analysis. And starting from this group tried to differentiate between what is edema and what is non-perfusion. And this is the figure that may summarize the results. This group, probably this one, no, sorry. Yeah, no. Okay, I have to do this. These are cystic spaces that can be detected on OCT-A. And these grayish areas were defined by the authors as areas of non-perfusion. So it seems that if we just look at OCT-A, we can distinguish between edema and non-perfusion. Unfortunately, this is not completely true. As more or less a year ago, there was this publication introducing a new term that is SPIM. SPIM means small particle emulsions that are in the cysts. And these are these grayish areas inside the cyst that are detected by OCT-A as movement, so as flow. But indeed, this is not flow. And so you can see how also cysts, based on the SPIM analysis, may appear as grayish. So nowadays, we cannot state that if we see something that is grayish, this means non-perfusion, because also cysts may have this appearance. And starting from this, we also did this study that is still not published, in which we tried to compare different devices looking at SPIM and non-perfusion, what we call region of interest. As you can see here we have two different devices. These cysts that are characterized by SPIM are well visible with this device, but are not well visible with this device. And this is a magnification trying to highlight this aspect. But it's even more striking when you look at this image, in which you can see that these cysts that are somehow hyper-reflective, characterized by SPIM, when we look at the same analysis with a different device, well, we cannot detect this SPIM. And this, again, also for both the superficial and the deep capillary plexus. So we can still see cysts as SPIM with this device, but we cannot see the SPIM with another device. And these are two different devices. One is a spectral domain, and the other one is a sweat source. So based on these results, we can say that all the results that we can have in our patients are strictly related to the device that we are using. So we cannot compare different devices. We cannot compare different technologies. So, so far, we cannot state in a universal way if what we see as a hyperreflective means non-perfusion or cyst or whatever. Then this is probably the first publication looking at the microaneurysms, and the authors looked at a localization of microaneurysm at the different levels, so superficial and deep capillary plexus, and tried to make a correlation with the localization of cysts. So as you can see from this slide, here we have the superficial capillary plexus, and here the deep capillary plexus. Well, the majority of microaneurysms associated with edema, with cysts, are located in the deep capillary plexus. So more or less in line with what was demonstrated in eyes with diabetes, but without diabetic retinopathy, it seems that the majority of changes in diabetes are located at the level of the deep capillary plexus. And indeed, microaneurysms that are responsible for development of edema are located mainly at the level of the deep capillary plexus. Starting also from this, we did an analysis of microaneurysms, and we realized that there were microaneurysms that were well visible on dye angiography, so on fluorescein angiography, that appeared as hyperreflective inside and were well visible on OCT-A. At the same time, we have microaneurysms that are still well visible on dye angiography, but that appear as hyporeflective inside and that are not visible on OCT angiography. These are different features that probably are also related to different characteristics and likelihood of development of exudation. So probably if we have a microaneurysm that is hyperreflective and that is visible on OCT-A, well, this will develop edema over time differently from a microaneurysm that is hyporeflective and is not visible on OCT-A. And this was the further question that we had, and also this was published a year later in the American Journal of Ophthalmology. So we looked at these two main characteristics of microaneurysms over time, over a year, and we realized that those microaneurysms that were well visible on OCT-A and that appeared as hyperreflective inside were those that developed exudation over time, over a year. On the other hand, those microaneurysms that were hyperreflective inside, that were not visible on OCT-A, well, these microaneurysms were still over time, so no development of exudation. Based on this, we hypothesized that microaneurysms that are well visible on structural CT and on OCT-A are those more exudative. On the other hand, those microaneurysms that are not visible on OCT-A and that appear as hyperreflective on structural CT are those that probably are more related to ischemia. So this is another kind of biomarkers. We have just seen the biomarkers on structural CT, but also CTA may be considered as biomarkers. If we have an exudative disease with more hyperreflective microaneurysm, probably we should treat this as an exudative disease. If we have a more ischemic disease, then we have to treat this as a more ischemic disease, and this is the case of microaneurysms that appear as hyperreflective and that are not visible on OCT-A. Then we, and this is the last topic of my talk, we try to investigate if all edema are the same. And we looked at diabetic macular edema versus post-surgical edema by means of OCT-A, of course. So we had two different populations with edema and a control group. And the patients were then treated, and we looked at the outcomes of treatment. The two diseased groups were similar for what regards clinical characteristics. And after treatment, we found an improvement in visual acuity and central macular thickness in both groups, so in both DME and post-surgical edema. But when we looked at the features on OCT-A, we realized that microvascular abnormalities detected on OCT-A in DME were much more frequently detected as compared to post-surgical edema. And also, this alteration after treatment, and we did the same treatment, an anti-inflammatory treatment in both groups, we found an improvement in the post-surgical treatment that was not detected in DME. This is just to show you some examples. So these are the changes, the microvascular changes that were qualitatively analyzed by two readers, and this was in DME, and this is in post-surgical macular edema. So you can nicely see how they are much more frequently detected on DME. Then we looked at the outcome of treatments, and actually we found that not only these qualitative features were more frequently detected in DME and did not respond to the treatment, but also vessel density was still more compromised in eyes with DME as compared with eyes with post-surgical macular edema, and this was both at baseline and after treatment. So in a sense, we had an improvement in the post-surgical macular edema after treatment that we did not detect in the DME. And this is an example. So this is the post-surgical macular edema before treatment, superficial and deep capillary plexus, and this is after treatment, superficial and deep. So you can see how there is a kind of improvement in the deep capillary plexus in this group that was not recorded in the DME group. So exactly the same at both superficial and deep capillary plexus before and after treatment. So probably a different mechanism, and we know that there is a pathological pathway that is inflammatory in both diseases, but probably not exactly the same, are also responsible for the development of macular edema and also for the response to macular edema. So we have a good response in post-surgical that we cannot detect with different treatment. We already know about anti-VEGF, but also with an anti-inflammatory, we have no improvement after treatment. So to sum up, OCT-A is nowadays a very important tool that we have in our hands to make diagnosis and to follow our patients with different aspects of diabetes and diabetic macular edema. We can probably detect the very early signs of diabetes in diabetic patients by using OCT-A that otherwise could not be detected with structural OCT or with fundus examination. We have certain characteristics like SPIM that prevent to use the same terminology for all different devices, OCT-A devices. We know that probably the majority of the disease is localized at the level of the deep capillary plexus in patients with diabetes and with the diabetic macular edema, and that this seems not to respond to whatever treatment. Probably we have certain characteristics that is, in the end, visibility or non-visibility on OCT-A for microaneurysm that may predict the progression over time, but also may target our treatment in a sense. We have a more exudative one, we have to treat the exudation. If we have a more ischemic one, we have to prevent continuous ischemia. And we have no improvement in DME, but we can have this improvement in other inflammatory diseases like post-surgical macular edema. Thank you very much for the attention, and thanks to my coworkers.
Any questions to Professor Querques from the floor? So I want to ask you, Giuseppe, about the reproducibility. I understand that if you look between two instruments, no reproducibility. But even within the instrument, when you talked about the microaneurysms in the deep plexus, how reproducible is this measurement, the numbers? Was it even studied if two people will look at it 2 times of the day? I don't know. And it's crucial, I think, to know this within the instrument.
Yeah, this is a very good point. Looking a little back to SPIM, let's say, or region of interest, because we tried to differentiate hyperreflective areas with hyporeflective areas. And well, we not only found differences between 2 different devices and technologies, but also within the same device. And the examination were taken in 2 minutes apart, so exactly, really quickly. This is probably even more important for microaneurysm because we know how flow may change there. In our study, we did not check over time microaneurysm. I mean, not twice in a short time period, and we also did not look over time between the different devices. But I suppose that there may be strong differences. What I can only propose and suggest is to use always the same machine when we try to follow the patient, at least. Yeah. But also in this way, we are not sure about.
Thank you, because for example, in regular OCT, you have 10% difference between morning and evening. So
yeah, and this will be. It was also demonstrated for OCT-A that from different moments of the day, but also after exercise or something else, may change dramatically.
Thank you very much.
Thank you very much.
So now it's a great honor to have Professor Raphael Sznitman, who is an engineer, a professor of engineering, specifying on artificial organs, focusing on artificial intelligence. What could be better for us that we are trying to understand a little bit artificial intelligence? We are very, very honored. Please, Raphael.
Okay, good morning, everyone. So thank you for the invitation, and hard to follow up after 3 fantastic talks. So as was mentioned, I'm gonna change gears a little bit, coming from more the engineering side. So I'm a computer scientist by training, and I'm really gonna be talking about the artificial intelligence part mainly. And so this work is really in conjunction with our clinical collaborators. So this is at the Bern University Hospital mainly. So I'm going to start off by talking a little bit about why ophthalmology and artificial intelligence are so interesting from a data science perspective. And for me, it all began, well, my disclosures, but all of this really starts with understanding the process of how patients are actually managed. So you have an eye disease, and a patient comes to your clinic, to your point of care, and there's often a diagnosis and then a treatment that's associated. But what's particularly interesting in ophthalmology is that for the vast majority of patients, you have these repeated visits. It's a management problem more than anything else. This is especially so for AMD and diabetics, but also for glaucoma. Okay? So this ensures, in a way, a data pipeline that is recurrent and very often happening in a way that is recurrently happening over months, if not years. Above that, perhaps more importantly, is that in ophthalmology, imaging plays a critical role. This goes from fundus photography, OCT, but also perimetry, and also interventional procedures, so in microsurgery, of course. And from my perspective, from an engineering perspective, this is the picture. There's always an imaging device that sits between the patient and the physician. It's that simple. And what that implies is if you have AI technology, that this technology can somehow integrate the device itself, or potentially provide some clinical support for a physician directly, and as we're starting to see, actually empower patients directly through phones and apps and websites, right? So once you have an AI technology, there's hope for it to integrate forward. So I'm talking a little bit about what I mean by AI technology. This is going to be my technical slide, so please bear with me just so that we have the right understanding altogether of what I mean by AI. What we mainly talk about AI today in ophthalmology, because it's so heavily focused on imaging, is ways to teach the machine how to interpret image data. And this is happening through data and large amounts of it. So I'm going to start off with an example, and this example is a little bit, it's not in the retinal. Well, it's cases for retinal blastomas. So here, these are cancers of the eye. This is an MRI of an eye. And what we have to start off with are a substantial image data set of patients. And in this case, we have a radiologist that has manually delineated, so this is what this green outline is showing here, manually delineated where the tumor is. Okay? And you do this over multiple volumes in these 3D MRIs. This takes an enormous amount of time. And once you've done that, you pass this to a data scientist, a computer engineer, and our job at this point will be to try to characterize pixels, to try to differentiate, at least quantitatively, those pixels that are pathological in nature and those that are healthy looking. And then comes what's called the machine learning part. Machine learning is just an acronym for model fitting at best. So here, the model I'm showing you is just a straight line, something you've seen since you were 10 years old. It's a straight line. You know that to define a straight line, you need 2 points, and so that allows you to define a slope and an intercept, right? That's this blue line right here. It's the equation y equals ax plus b, where a and b are your parameters. And if you crunch around, you know how to compute a and b, and this defines your line. So in a really simple model like this, you have these 2 parameters. You can do it by hand, but you can see that you have errors, right? So some of the red points, which in this case consist of the healthy pixels, they lie on the wrong side of this discrimination boundary. Right? So what machine learning really talks about is complexifying this line into more complex models, where instead of having just 2 parameters, you maybe have 1,000 of them, or 2,000, 10,000 parameters. So there, doing it by hand is not reasonable, and that's why you need computers to solve the parameters of this model. Because once you have it, you can actually use it to do prediction forward. And so in this case, it allows you to predict where the ocular tumor delineation may be in a new patient. Okay? And so we've done this in, well, and the hype that's come out of the last 5 years, roughly, is deep learning, which is a way to combine this engineering part with the machine learning in a single step. Okay? It allows you to bypass a lot of the hard effort that went into feature engineering. And then you can start playing with this idea. So here are some results on a fairly large, small study for retinoblastoma patients. Using T1 and T2 MRIs to delineate these tumors. And in some cases, it does quite well. It allows you to bring out some decent results, and sometimes it's just off, okay? And the understanding of why this is happening, so in red are the demarked by hand, and in green are actually the predictions of the method. So in these two cases on the left, they're doing quite well, and on the third one, the third column, it's pretty awful. And so this quality that we're seeing in the predictions is a consequence, in this case, of the amount of data that's used to train these deep learning methods. In this case, it's only around 35 patients that was used to train the model, which is relatively few. Okay? But we can look at other cases or in other environments where deep learning is starting to appear in ophthalmology. And so this is just fresh off the press. This on the left, what I'm showing you is the Price Eyes robot for retinal surgery that was CE approved just earlier last week, 4th of June of this year. So now this is now CE marked device. And what we're seeing out of these instruments is that the hope is to provide better tools for the future. And what we have on the right is visual tracking of a surgical instrument, a gripper, in order to provide a stabilizing ability for the surgical hand. Okay? So here we're using deep learning to visually track the instrument during the surgery and to provide some control for the physician that's more minute than by hand. Okay? So this is one area. Another is in the area of perimetry, very different. So if you're not familiar with perimetry, the idea is that the patient focuses on a specific point in the globe, and then is presented with visual stimuli that flashes around, and whenever they witness a stimuli, they press a button. There's roughly, on this right, you'll see there's roughly 60 locations that are typically tested for glaucoma, and this provides you after with a patient visual field on the left side. And all in all, we're talking about 6 to 8 minutes of testing for a standard eye, that's glaucoma eye. And the question now is, well, can we somehow speed it up? Because the burden for this examination falls pretty much solely on the patient. It's very long and tiring. So you can imagine that if for 60 locations it takes 8 minutes, if we somehow randomly said, well, let's half the number of locations you actually want to test, it would be a 4-minute exam, but the visual field would be sparse and useless. Okay? But the idea is that, well, maybe we can approximate and fill in the gaps of what was not actually imaged, and by multiplying the actually recorded locations with some weights that are actually going to come from the machine learning part. Okay? This is where the AI comes in. And if you can do this for 4 minutes, you can also do this for 2 minutes and 30 seconds if you also wanted to do so. And so we've done this now in a roughly 100-patient prospective study, looking at a variety of different perimetry strategies. So on the y-axis, you have error of the acquired visual field, and on the horizontal, on the bottom here, you have time, or number of presentations in the perimeter. And so in perimetry, you always have this speed-accuracy trade-off. You can get visual fields very quickly with low quality or very slowly with high quality. And this method that I show you that's using this AI to fill in the gaps is this green line. So you can stop it whenever you want as a user and see what the accuracy you would produce if you were to actually use it. So we see we have a better compromise in terms of speed accuracy using these kinds of systems. So I'm going to focus the rest of today on OCT because there's been a lot of discussions about how AI and OCT can work hand in hand. And what I'm going to focus on is really how can we automatically produce a set of biomarkers from a given OCT volume. So what I'm talking about here are the vast literature that's given us in terms of different biomarkers. So these are visual patterns that are coming into or visible in the OCT. And the ultimate goal that we were interested in having here is you take a scan and then you get a printout of all the biomarkers that are actually present in this volume and potentially where they are and to quantify them down the road. Okay? So the problem statement is quite simple. You have a B scan, because in our clinic, sometimes we just take single B scans, and we'd also like to have this answer, so not always just a volume. So from a single B scan, what biomarkers are present in this image. So this is a problem we want our AI system to be able to solve. And our key assumptions here is that the set of biomarkers, we're going to predefine them. In our case, we have 10 of them. I'll show them in a bit, 11 actually, sorry. And above all, we don't want to specify where they are, okay? Because to teach our method how and where these locations are would imply having to delineate these biomarkers, which is very time-consuming. Instead, we took a different approach. We set out, well, let's try to annotate 20,000 B scans. And to do that, we set up a web-based platform that allows you to upload, in this case, Spectralis data. So you can load your volumes, you can tag every B scan with different biomarkers that we had pre-listed. You can also tag it with different diseases that you might have in a specific scan or in a different complete volume, and you can shuffle through and propagate labels all the way through a volume. So this allows you to very quickly annotate what biomarkers are present, and you can do it in parallel. You can even do it in front of on your couch when you're watching TV half awake. So the idea was to have really a fast system to annotate large amounts of data. And here we were doing this on AMD and DME eyes. And in a matter of a week, we were able to collect roughly 20,000 B scans from our patients. So what's critical, and this was raised earlier, was the question of definitions. So after really specifying what we meant by every single biomarker that's listed on the horizon here, we were interested in understanding how well do experts do this. So these are 9 graders that have done the same images. They have graded the same images for the same biomarkers. And to evaluate how well do experts perform this task. So on the vertical here, we have the Kappa's coefficient and the different biomarkers. And so what's clear is that some biomarkers are very easily identifiable. So these are healthy and SRF, GA as well in large parts, ERM. But some of them, other ones, are slightly more complicated. The variance is much higher. So outer retinal atrophy and reticular pseudojusins in particular. And the variance is also much, much higher. Okay? So here, human performance, even trained and so-called experts, is complicated. That's the first takeaway. And when you use an AI system to try to perform the same task, this is where this blue point lines up. Okay? So what you can see is that on average, it pretty much always falls within the variance of human annotators, so 9 of them that have been trained to do so. It's not always doing better than the median. So in particular for SRF, we're below the median, which is very high at a 0.93 kappa value. But for healthy and for the difficult cases, in particular ORA, we're doing quite well. Okay, so here the performance of an AI system is pretty much at the level of an expert, the average expert physician. Okay, and from this now, we can in fact extract location information. Even though the system isn't trained from location information, we can inspect using what are called class activation maps. This is identifying what part of the image is giving evidence to the system to decide what biomarker is present. So on the far left here, on the bottom left, we have SRF. So it's a little hard to see at the scale, but you can see in red the areas of the image which are focused by the system to decide whether it's not. And it happens to coincide pretty well. HF, so hyperreflective foci, these are pretty much lining up with this pattern that's happening, IRF, ERM, and GA as well. Interestingly enough is the case of healthy. So healthy in our protocol was really the absence of all other biomarkers. And so it's not surprising that the system is highlighting the entire image because it has to evaluate the entire image to make the assessment that nothing is there. So this is, in a sense, reaffirming our assumption of what these systems were supposed to look for. So once you have this, we were interested in slowly and potentially integrating this into a useful tool, not just a research tool. And so this is an online system that allows you to download your OCT data, upload it onto a website, and run this algorithm in the background to inspect pretty quickly what is happening. So here what you see are the 1 through 49, the 49 slices of a spectralis OCT images and the different biomarkers. And so very quickly you get a bird's eye view of what biomarkers and where they are located. So ERM in this case is very heavily present throughout the central part of the volumes. You have some healthies on the upper and lower parts of their volume, which makes sense. But what we also see is some cysts, some intraretinal cysts, and some intraretinal fluid that has pretty much been found in the central part of this OCT. Okay. And once you have this, you can now start replicating this on population statistics. So here what I'm showing you are 4 different diseases, and again, our biomarkers on the bottom. So in red are all the healthy OCT scans, and so unsurprisingly, the vast majority of biomarkers found for healthy cases are the healthy biomarkers, which makes sense. We have a little bit happening in ERM, but after that, we have drusen, which really is dry AMD in this case, and so we have lots of drusen, a little bit of fibrovascular PEDs, and reticular pseudodrusens as well. And CNV and DMEs are following patterns that are reflected in the literature, with DMEs having lots of IRF and intraretinal cysts, and CNVs some subretinal fluid as well. So we can now very quickly analyze population-level statistics for diseases. So beyond that, we can now start looking at things from a treatment recommendation point of view. So in Bern, what we have is a treat and extend protocol for AMD patients. And while the real question is, do we extend or not whenever a patient comes through, we can convert this in an approximation of, is the eye dry or wet? And so using these biomarkers, you can compute an ROC curve to see the performance you would have in this assessment of actually recommending to extend or not. So here we're talking about, is the eye dry or wet? And then from a retrospective analysis of roughly 1,000 patients, and every scan takes now a second to process, you get a performance which is pretty much in line with what we're seeing from the IDX system. So that's what this green point right here is. This is the sensitivity and specificity performance of the IDX system. So you're getting at levels which are substantially high. And this is not now in a screening mode, but in a disease management mode, which is slightly different. So the takeaway that I'd like to finish up on here is really that from a data science point of view, AI and ophthalmology are really an ideal pairing. And that's because the data protocol to acquire images is very standardized and very nicely organized. And this allows and gives way to huge amounts of data of high quality. And this is not just for OCT or fundus photography, but actually spans much wider ophthalmology cases as well. And with that, I'll wrap up, and I'd be happy to answer any questions that you may have.
Thank you, Raphael. We do the discussion at the end of the artificial intelligence part. Thank you so much. Next talk will be Imaging Geographic Atrophy, the Role of Artificial Intelligence by Maximilian Pfau from Bonn, Germany.
So, dear Professor Loewenstein, dear Professor Wolf, thank you very much for the kind invitation. So my role is now very specified to one single disease. As you all know, age-related macular degeneration is one of the most common causes of legal blindness in the Western world. And for the very elderly patients older than 85 years of age, geographic atrophy, the so-called non-exudative late-stage manifestation, is even the most common form. And despite of more than 40 therapeutic treatment trials, no treatment could be identified so far. So what are the reasons for that? And one can think of multiple challenges. The first challenge is that within a population of what you would call clinical geographic atrophy, you have some patients with rare monogenic diseases. Then if you look at GA patients which really have AMD, there are again different subgroups which behave completely differently. And last, you need for clinical trials responsive structural and functional endpoints. And for all of these three challenges, which I've shown here, there are solutions which are somewhat AI-based, which may help. So for the first challenge, here you can see 3 patients. All 3 patients exhibit RPE atrophy and some kind of yellowish deposits, but it's really hard to really tell the diagnosis. So if you do en face OCT scanning, again, you see the RPE atrophy and the different OCT layers, but only fundus autofluorescence really helps you, and if you then do genetic testing, you see that the patient on the very far left has late onset Stargardt's disease with ABCA4 mutations. The patient on the very right hand has central areolar choroidal dystrophy, and only the patient in the center has real geographic atrophy secondary to AMD. And here AI can come in. So there has been this really famous paper from Moorfields and DeepMind last year, and it has shown that you can have a multi-class classification based on OCT data for gross disease categories to distinguish AMD, exudative, non-exudative, retinopathy, or RCS, or vitreomacular attraction. But the main problem is, as of now, there has been no publication of a classification algorithm for these fine categories, as I've shown beforehand, like late onset Stargardt's disease and so on. So there's still an unmet need, but in principle, the technology appears to be available. Then the second challenge is subphenotyping. So this is a patient with GA secondary to AMD, and as you see, for a very long time, the lesion doesn't expand at all. And of course, such a patient you wouldn't want to have in a clinical trial because it would completely provide no information with regard to drug efficiency. And the traditional way to do it is to use this fundus autofluorescence classification and to only include eyes with the so-called banded fundus autofluorescence phenotype in clinical trials, to only select lesions that are larger than 1.25 square millimeters because they tend to progress more rapidly. And last, with these criteria and with some other criteria such as lesion circularity and focality, you can build normal models that can explain up to 40% of variability in progression rates. Now, with AI-based methods, there's one paper which has already been published by the Stanford group of Daniel Rubin, and there's also one paper in review by our group. You can even predict future progression rates, and these models provide a slightly better prediction of future progression rates, explain up to 40 to 50% of the progression rates. But the big problem so far is our algorithm hasn't been published so far, and for the other algorithm, the weights or the machine learning model itself has not been publicly made available in the publication, so there it's not possible to validate these algorithms on independent data sets, which overall constitutes a rather big problem. Then the next issue are structural endpoints, and as we've heard before, it's quite time-consuming to measure areas of geographic atrophy. The current gold standard is the region finder method, which allows to do it with a rather high accuracy with a coefficient of variation for the area measurement of less than 4%. But again, this is something obviously where AI methods can help. Previously, we had some machine learning approaches to quantify areas of GA, and we also, from our group, had this deep learning-based algorithm for drusen segmentation, and it really can make the time to quantify these features much shorter. But again, the big problem is all of these algorithms and pre-trained neural networks have not been made publicly available. So typically it's very difficult to compare the results between the different groups, because obviously in papers you never know if there's some bias or if there has been so-called overtraining. And then the very last part where I want to talk about a little bit more is the challenge of functional endpoints. So the conventional functional endpoint, which is used by most studies in ophthalmology, is best corrected visual acuity with a BCVA chart. And as you see, some patients in geographic atrophy exhibit foveal sparing. It's not well seen on fundus autofluorescence imaging because of the macular pigment, but in the IR image or in the en face OCT image, you can see this patient has a spared fovea. And typically these patients, they still have a very good visual acuity because, again, the fovea is spared, so they're able to read single small letters, but they complain massively because they can't read in their daily life. They don't have a chance really to function for normal activities. So best corrected visual acuity as a functional endpoint in geographic atrophy doesn't make much sense. The alternative, which works theoretically quite well, is so-called fundus-controlled perimetry. So it's basically perimetry testing, but with simultaneous imaging of the fundus, and it really allows for spatial mapping of cone function of the retina. And now we also have dark-adapted fundus-controlled perimetry, which allows for spatial mapping of rod function. And the ideal thing about this, even if the patient can't fixate stably, you still can get a map of retinal sensitivity all over the fundus, but it's very time-consuming, especially the dark-adapted testing. You have to put an elderly patient into a room for 30 to 40 minutes to dark-adapt. If they have to go to the toilet, they have to dark-adapt again, so extremely time-consuming. On the other hand, nowadays we have multimodal imaging. It's broadly available, well-established. It requires really no time at all. A scan takes by a maximum 2 minutes. And it also requires, compared to the functional testing, really minimum patient cooperation. So what I want to present now is ongoing work where we ask ourselves, can we somehow predict retinal sensitivity based on this quick multimodal imaging, which we can do really easily? So the purpose is to investigate the impact of retinal microstructure on cone and rod function in eyes with geographic atrophy, and to apply machine learning algorithms to then predict function based on structural information only. What we did, we included 43 patients of 43 eyes with GA. We conducted multimodal imaging with these imaging modalities. The SD-OCT data was segmented in a semi-automatic fashion for these retinal layers, 7 layers in total. And then we did fundus-controlled perimetry, and we did not only do mesopic testing, which tests mostly cone function, but we also dark-adapted the patients for 30 minutes and then did dark-adapted red testing and dark-adapted cyan testing to get 2-color dark-adapted perimetry to separate out rod function in these patients too. And we then used this data, which we got from the fundus-controlled perimetry. So here you see the stimuli with retinal sensitivity, and registered that to all of the imaging data and then tried to predict function. And what you can see here, which is quite remarkable, if you include only imaging data only, and we trained the data on 42 patients and always used the last patient as test patient, so we did leave one out cross-validation, then you can predict retinal sensitivity with an average error of only based on imaging data for each test point of around 4 decibels. And this is also almost in the same range as the retest reliability of perimetry itself. So if you repeat the exam 2 times after each other, the points will vary in about 3 to 4 decibels as well in terms of sensitivity measurements. But then again, in a clinical trial scenario, it would also be acceptable to have like this predictive algorithm of predicting function on perimetry, but some patients, which you can see here slightly in gray, there the prediction was really inaccurate. So we thought, okay, if you have a brief perimetry test, the same idea as we have beforehand, and then add the imaging data, can our prediction accuracy get better? So if we add the information of 30 test points, which is a very short test, then the prediction accuracy for all the remaining test points gets even better to an average error of 3.1 to 3.0 to 4 decibels for perimetry testing. So you can really precisely predict sensitivity. So how could you use this inferred sensitivity in clinical trials? You could basically have one subgroup in clinical trials of the, I say, more fit or slightly better of patients from a mentalist perspective, and do extensive psychophysical testing and volumetric multimodal imaging. And then you could also have your regular large clinical trial cohort where you mainly collect the structural endpoints, and then you could use this machine learning-based inferred sensitivity to compute function for this subgroup as well. And it also allows you to produce these beautiful maps. Again, this is the multimodal imaging data used to predict function, and this is the predicted function. Here you see the predicted cone function, and here you see the predicted rod function. And you see you have a very high resolution, much higher than you could ever test with a normal functional test, because you couldn't put that many test points into any patient. And also what's remarkable, the algorithm correctly identifies that quite close to the atrophy boundary, cone function is already quite reasonable well again, but close to the boundary to GA in dark adapted testing, you see the significant cyan minus red sensitivity difference, which indicates severe rod dysfunction. So it really can identify from the very same image that here you have good cone function, but severe rod dysfunction, something which from a pure clinical point would be difficult to pick up from the OCT. So in summary, we have artificial intelligence and machine learning approaches which in principle would allow for differential diagnosis of retinal diseases, but so far we are lacking. We have only these gross disease categories, but these fine disease categories such as late onset Stargardt's disease, central areolar choroidal dystrophy, and real GA, we don't have an algorithm for that yet, but from a technical point it would be feasible. Then the prediction of future progression rates is also possible, as shown now by 2 works, and this allows for subphenotyping to really select patients with rapid progressing GA for clinical trials. We can quantify GA lesions and disease-associated features with deep learning algorithms, which will be really time-saving for future clinical trials. And then this prediction of retinal function will also allow for time saving, because now we can have like high resolution functional maps for every patient without the requirement of excessive functional testing. However, there is currently really a lack of publicly and commercially available software solutions, so I was really excited to see by Bern this online solution, because I mean the next step will really be to make these tools publicly available so that other groups then can revalidate the diagnostic accuracy of these algorithms with other data sets which are truly independent to avoid any overfitting. Thank you very much.